So on behalf of SigTuple, I'd like to welcome everyone here today on this lovely evening. We're going to be kickstarting a brand new series of education, and I would like to first introduce our distinguished speaker for today's evening. So our distinguished speaker today is a seasoned consultant pathologist with more than 21 years of experience. It's my absolute pleasure to introduce Dr. Priya Murthy, and I would request all of you to join me in welcoming her today. And her work has significantly shaped the way we diagnose and understand hematological disorders. We are privileged to have her here today to share her insights on this topic of a universe of clues approach to screening peripheral blood smears where art meets science. A little bit more about her. Dr. Priya has completed her MD from Bangalore and is currently heading the laboratory and blood bank operations at Sparsh Hospital, Bangalore. She has a very good history of working for many years in the field, including hospitals like Apollo and also chain laboratories like Dr. Lal Pad's lab, Onquist Laboratories, Metropolis, etc. She has experience in various fields of pathology, and her prime interest and where she will be sharing her knowledge with us today is in hematology. She is also an expert in clinical pathology and QA, and her special interests include bone marrow, morphology, and flow cytometry. She's been a guest speaker in various platforms. I've heard her talks in the past, and you'll find that very intriguing to listen to her insights and views on hematological practice and the interpretation of peripheral blood smears in particular. So over to you, Dr. Priya. She has contributed in various chapters for hematology textbooks, and she also has many publications on her credit. We await to hear from her, her insights and her views on today's topic. Over to you, Dr. Priya. And yes, thank you very much for gracing your occasion on this occasion with us here today. And we look forward to hearing from you.
Thank you, Dr. Renu. That was a very kind introduction. And I hope you're able to see my screen now.
Yes, could you just put it on the
Yes.
share mode? Yeah, presentation mode. Yeah, there you go.
Yeah. So good evening to everybody. Thank you for joining on a Saturday evening. And I'm sure the last week has kept you very busy and you're looking forward for a relaxing weekend. I hope with this talk, you may be able to relax and also, just think about where we can improve our interpretation of peripheral blood smears. And after my short presentation, we can have some interaction as well and share our experiences on this platform. I think that should be fine, Dr. Renu. With the advent of a lot of advancements in hematology analyzers and with newer parameters that are coming into play, many institutes have revised their peripheral smear review criteria. And also because of lack of trained staff and lack of manpower, lack of if you consider in remote places where there are not many trained staff and we don't have people to interpret peripheral blood smear, reports, whatever we are getting on the automated cell counters are released. And really is, I feel peripheral blood smear examination has become a lost art. And that is why the topic, what we just described right now, but peripheral smear is very important. It is invaluable in characterizing a number of diseases. It's an inexpensive and a very powerful diagnostic tool to give rapid, reliable access to various hematological disorders. So if you have to define what a peripheral blood smear is, the very basic and highly informative hematological tool used for screening, diagnosing, and monitoring of disease progression and therapeutic response. The diagnostic relevance has not been lessened by advances in hematology automation and molecular techniques. So, if we just go through the history of peripheral smear examination and how hematology came into the foray today, in 1974, RBCs were first described, and subsequently, there were a number of devices developed to count RBCs and WBCs, my hemocytometers, my various investigators. In 1878, Ehrlich developed blood cell staining, and following which he described granulocytes, mast cells, polychromatophilia, megaloblasts, etc. In 1898, Wright optimized the stains, and then he could differentiate between the different types of cells. And by 1934, we could classify anemias based on RBC indices, and which was introduced by Winthrop. So the cell counters came into a picture in 1950, and the Coulter principle, we all know, was developed by Coulter, and a number of technologies have come into play, including electrical impedance, optical cell counting. And in 1970, the first three-part cell differential cell counter was introduced. Blood film examination will still help you, despite all these advances, to diagnose a disease, monitor responses, detect any pre-analytical or analytical error in the output of automated analyzer, correlate any instrument flag, and a lot of additional information can be derived when you actually fall in love with examining a peripheral smear. A peripheral smear also becomes an integral part of a bone marrow examination report. It helps you correlate when you're examining a bone marrow and you also have a peripheral smear with you. It gives you a lot of information and helps you to make a better diagnosis on a bone marrow. So, RBC disorders, including several features of hemolytic anemia, can be picked up while examining a peripheral smears. WBC disorders, especially in subleukemic leukemia, your hematology cell counter may just give you a total count, and then it may not exactly be able to, some flags may come up. Very low counts, such as 900,000 cells of WBCs, if you're able to patiently screen, you may pick up one single blast that will give you a clue, and you can pass it on to the clinician, who may then go on to examine the bone marrow. And voila, you may be able to pick up a leukemia much earlier than expected. Presence of all rods in any of the cells will help you conclude it is a leukemia. Neutrophil defects also can be picked up very easily. And in ICU patients, if these neutrophil defects are picked up, it will help prognosticate the course of the disease. Platelet disorders, platelet size and morphology will give you a lot of clue. For example, if you see giant platelets in a case of thrombocytopenia, you know that the bone marrow is actively responding to the disease and it is producing the platelets. In case in a thrombocytopenia, the platelets are very small and normal in size, then you will have to think of defective production of platelets in the marrow. So, in this educative series, what we have planned along with SigTuple and Dr. Renu, in the first session, we will be talking about examination of a peripheral smear. In general, we'll also talk about some artifacts and troubleshooting. And the RBC morphology, WBC morphology, platelet morphology, and hemoparasites will be taken in the subsequent talks. So let's begin with a case. So we have a 26-year-old male. He's presented with weakness for the past 8 months and a mild persistent jaundice. He's in a white-collar job, vegetarian, and no precedent drug intake. So when the physician examines, he's barely able to feel his spleen tip. Otherwise, there are no liver enlargements or lymph node enlargement. Now, this is the data that we got from the hematology analyzer. What do you see? Hemoglobin is reduced, total count is reduced, platelets are reduced. Differential is normal, MCV is on the higher side. So when we examine the peripheral smear, this is what we are seeing. These, I'm saying, are larger than normal RBCs. They are abnormal because they are oval in shape. They're macrocytic, ovalocytic, and I'm also finding a normoblast. This is a normoblast, which doesn't look really normal, like a normal normoblast. Just a second. Okay, now these are pictures from more areas of the same smear. What we are seeing are these cabo rings. Then we are seeing multiple purple dots, which is called basophilic stippling, another nucleated red blood cell. This looks okay, normal, but what we saw earlier was not normal. Then these purple RBC inclusions, which are the Hubble-Joly bodies, and hypersegmented neutrophils. With this, we could make a diagnosis of megaloblastic anemia. These are features that a hematology analyzer will not be able to pick up, and you will be able to pick it up only when you examine a peripheral blood smear. So if you saw the MCV was very high, and if you look into the differential diagnosis of a macrocytic anemia, there are multiple plausibilities. You will have to do a reticulocyte count to rule out reticulocytosis. And then we will be discussing more of this in detail in the subsequent talks on RBC disorders. You can come up with a number of differential diagnoses. Now, if the same patient had to undergo a bone marrow examination, of course, this is not from the same case, but some pictures that I already had. So bone marrow will show you megaloblasts. These are the early megaloblasts. You will find hypersegmented megakaryocytes. These are the dyserythropoietic normoblasts. And if you do an iron stain, you will find these abnormal sideroblasts. Iron stores will be increased in a case of megaloblastic anemia. The myelopoietic series also are giant with bigger than normal. These are the giant metamyelocytes that you come across here. And if you see a bone marrow biopsy, you see these clusters of early megaloblasts. So megaloblastic anemia is a dyserythropoietic anemia or defect in erythropoiesis, which leads to an abnormal erythroid cell population. These abnormal erythroid cells either die in the marrow or mature into abnormal cells. These abnormal cells have a shortened lifespan. If they die in the marrow, obviously you find your biochemical values like LDH and serum bilirubin are all increased, and they give you a clue. So dyserythropoiesis is one of the megaloblastic anemia is one of the dyserythropoietic anemias. There are several more, and we could discuss this in the RBC disorders. Now let's look at another case. This is a 38-year-old female with weakness and general abdominal discomfort. She had some abdominal discomfort. There was no organomegaly, and her ultrasound also was normal. Now, this is the peripheral smear of this patient. What are you seeing here? Or I have pointed out at all the arrows. The RBCs are macronormoblastic. There are ovalocytes, teardrop cells. There are nucleated red cells. There are immature myeloid precursors in the peripheral smear. This is what we see in a leukoerythroblastic blood picture. Leukoerythroblastic blood picture usually calls for a bone marrow examination. And when we saw the bone marrow, it's aspirate, there were clusters of metastatic tumor cells. And likewise in the marrow, this was a fibrotic marrow with clusters of metastatic cells. So this fibrosis will give rise to the leukoerythroblastic blood picture. Now, this is the science behind the morphology of the cells in the peripheral smear. Very rarely, not in this case, but I had another picture. What I'm showing here are these are circulating um, carcinomatous cells in the peripheral smear. This is known as carcinocythemia. Very rarely you come across. Of course, this is not from this case, but I'm just showing you here. If you're able to pick these up, you can pick up metastatic bone disease. This is another case. Of course, here it is a child with stunted growth, and this child also has a leukoerythroblastic blood picture, teardrop cells, nucleated red cells, and immature myeloid precursors. But in this case, the cause of this leukoerythroblastic blood picture was a different cause. This was a case of osteopetrosis, which results in extensive marrow fibrosis, due to which you get a leukoerythroblastic blood picture. And this we could pick up with a skeletal survey. So peripheral smear forms a window to the bone marrow examination. Now, I have been telling you that the morphologic abnormalities that you see on a peripheral smear, it is either due to production of abnormal erythrocytes or due to a pathologic process uh, to which the erythrocytes are exposed to in the circulation. Now, for example, these are normal erythrocytes. Now, these hypochromic erythrocytes are due to inadequate hemoglobinization, and the large macrocytes, ovelocytes, are due to abnormal erythropoiesis, asynchrony between the nuclear and cytoplasmic maturation, giving rise to these macrocytes. Then similarly, you find normoblasts or nucleated red blood cells in the peripheral blood. It is because of some irritation in the bone marrow that has caused the normoblast to come out into the peripheral smear. If you see spherocytes could be because of an inherited membrane abnormality, or because some antigens are sitting on the surface of these erythrocytes, and the phagocytes have acted on it and caused these spherocytes. Stomatocytes are seen in overhydrated cells. Now, target cels. Target cells are these where there is, you can come across them in hemolytic diseases. You can see them in liver diseases. Target cells can also be an artifact. So you need to use your discretion on how you're going to label these cells based on the way the smear is made, based on the clinical history of the patient. All these have to be taken into consideration before you make a perfect peripheral smear examination. Likewise, basophilic stippling you come across in because of these are also found in dyserythropoietic anemias due to aggregates of ferritin, lysosomes, ribosomes in degenerated mitochondria, wherever hemoglobin synthesis is impaired. So this is the science behind the art. Now, to enjoy evaluating a peripheral smear, there are certain things that you really need to take care of. First and foremost, the quality of the smear and staining is very important. Now, if you're not able to get a perfect peripheral smear, if these smears are not made by experienced technologists, if the staining is not taken care of, you will not enjoy reading peripheral smears. The moment you get a beautifully stained peripheral smear in front of you, you will forget the whole world, believe me. So you have to take care to train your technicians to make the perfect peripheral smear. And there are some things that we need to take care of. Now, like for all lab investigations, pre-analytical is very important. Now, when we are taking smears, if in a diagnostic center, you may not come across, you will not completely have, you will not have complete history of the patient. But in a hospital setup, you will have a more access to the patient's clinical history and charts. So pre-analytical evaluation of the patient goes a long way in getting a good smear also. Now, if the patient is dehydrated, if the patient is on any diet, or if the patient has come after a heavy exercise, his WBC counts may suddenly be increased, and the same will be reflected in your peripheral smear. There could be some diurnal variations, like, for example, again, WBCs are increased towards the evening hours. So, having some history of the patient can also play a big role. Now, while making peripheral smears, I'm limiting my talk to only peripheral smears. I'm not talking about other pre-analytical issues. We have to be very cautious about patient identification. Now, your phlebotomist has collected 5, 6 samples and has deposited them in the hematology department. If you do not have automated slide makers and staining, then where you have to make it manually, it is very important that you identify each of the slides with the tube of the patient that it is made in. Now, phlebotomy technique also plays a very important role. If there is lot of manipulation during collection of the sample, unnecessarily there will be platelet aggregates, there will be RBC clumping. So, a smooth procedure, when you're able to access it easily and withdraw the blood, then you will be able to get a perfect smear also. And once the smear is collected, it has to be gently inverted 8 to 10 times so that the anticoagulant acts with the blood and keeps the blood from clotting. Now, samples collected from elsewhere reaching your lab, again, there is specimen transport becomes very important. There are sometimes logistic aids. We carry the tubes against gel-iced frozen ice packs. This will immediately cause hemolysis and will affect the quality of your smear. Or if he's picked up a number of samples and he's roaming around in the hot sun, by the time he reaches the lab, it is already 5, 6 hours. There will be changes that you see in the peripheral smear, which will not give you accurate results. So these are some things that you need to take care of. And for example, cold agglutinins. Cold agglutinin is a condition where RBCs are sensitized with IgM antibodies, and when exposed to cold weather, the RBCs immediately clump. So for these cases, if there are known cases, then you'll have to collect with a pre-warmed syringe, pre-warmed tubes, keep the tubes and syringe in a 37-degree water bath, and then collect it, immediately process. So these are some things you'll have to take care of. Pre-analytical plays a very big role in getting the right quality of peripheral smear. Now, choice of anticoagulant. So most commonly used anticoagulant is EDTA. So EDTA is a calcium chelator and prevents the blood from clotting. So EDTA, the pH of EDTA depends upon the salt of EDTA that is used. You get sodium EDTA as well as potassium EDTA, and then you get K2 EDTA and K3 EDTA. Now, what is recommended by ICSH is the K2 EDTA, because EDTA by itself is hyperosmotic and it withdraws the water from the cell, causing them to shrink. Now, when you lower the pH of the EDTA, like in K2 EDTA, which has a lower pH, it compensates for the osmotically induced shrinkage. So this kind of swells up the cell. So this is the K2 EDTA is the most preferred EDTA when it comes to anticoagulant. Citrate also can be used, but this is more preferred for coagulation tests because blood is diluted by about 10% and hence all counts will be lower. And platelets also appear larger in a citrate sample. Sometimes citrate sample becomes essential because patients who have EDTA, anti-EDTA antibodies, no matter what you do after collection, you mix the tubes well, they will still develop pseudo thrombocytopenia because the platelets will clump because of anti-EDTA antibodies. So when these patients, for them, you will collect it in citrate, and citrate will give you more accurate counts. Heparin is usually not preferred. It also causes some staining artifacts. So you have to take care that once you're collecting the tubes, You collect the blood up to the mark on the tube because insufficient either short filling or overfilling will alter the anticoagulant blood ratio, and this can also affect the quality of your smear. Now, what are the attributes of a good peripheral smear? It is usually tongue shaped, it has a smooth tail. Now, it has both these thick and thin areas, and it has no lines or holes. And if you see, it occupies nearly two-thirds of this glass slide. The edges do not touch the edges of the smear do not touch the edges of the slide. So it should be margin free except at the point of application. There are two types of smears we make. It's mostly the thin smear that we examine, but I will give you a little insight about thick smear as well. And some of the techniques for peripheral smear examination include slide technique, cover slip technique, automated slide making, and staining. There are also available in many laboratories now. So please use clean glass slides, which are free of oil and dust. Take a small drop of blood and it should be placed about 1 to 1.5 centimeters from the uh, edge of the slide. You should have a good spreader. This spreader should have a smooth edge which is not ragged. You will keep the edge of the spreader at an angle of 30 to 40 degrees. Slowly withdraw it back so that it touches this drop of blood. Wait for the drop of blood to spread along the line of contact, and then immediately you should give it a gentle push so that you are able to make a tongue-shaped smear. So it is this comes with practice. I generally make my new junior technicians just smearing for the first week of their joining, and which is not used for reporting, but they just practice smears. They just practice smears. Once they get the technique and they're able to smoothly make a peripheral smear, it helps a lot. If they are inexperienced technicians, the quantity of blood they take for smearing is also small, so that they end up making a very short smear. Or they may take a very large quantity of blood and they end up making a smear that goes beyond the slide. So, with experience, they learn to take just the right quantity of blood and make a smear that will cover two-thirds of the glass slide. If the edge of the spreader is not smooth, then the quality of smear also will vary. We'll just go through that as well. So it's important to take clean slides, and the spreading action should be smooth, not staggered, and angle of the spreader's slide is also very important. So when you do that, this is how you get in the tail end of the smear, the RBCs are discreetly placed, spread far apart, and closer towards the center they are just about touching or overlapping. And in the thick part of the smear, the RBCs are sitting on top of the other, or they look clumped and agglutinated. So if you take a very large drop of blood, the entire smear will look like this, and you will not be able to see any morphology of the RBCs, WBCs, or of the platelets. It's most important to allow the smear to dry completely before staining. Do not be in a hurry to stain the slides. Allow the smear to air dry completely before staining. So, after making the smear, the next important step is the staining. Now, Romanowski stains are most commonly used for peripheral smear staining, and they are a combination of acid and basic dyes. It was first introduced by the physician Dmitry Romanowski in the year 1890. He used a combination of moldy methylene blue plus eosin to stain malarial parasites. And this chemical reaction, which occurred between methylene blue and eosin, was known as the effect, and it became the gold standard in malaria detection. So there have been a number of modifications after he first made the stain for detecting of malarial parasite. By itself, methylene blue or eosin will just give some coloring. But when they are mixed in the correct proportion, and when it came as the years passed, many more investigators could add more dyes like azures of methylene blue were added to it. And this gave a contrasting effect and gave the various components of the cell were beautifully highlighted with addition of more azures. Now, there are different types of Romanowski stains. Leishman stain is what we use routinely. There is also the Wright stain, which was introduced by Homer Wright. Mainly, it included methylene blue and eosin in a certain proportion. Giemsa stain is a more significant variant of the stain. It was introduced by Gusto Giemsa. And here, along with methylene blue and eosin, some azures were added, which made the intracellular parasites and viral inclusions more prominent. Field stain is a rapid stain, which is like the name stain says, it is used on in large sized camps for rapidly staining smears to pick up malarial parasites. And May Grunwald Gimsa stain is another way iteration of the Romanowski stain, and these were made by the contemporaries of Romanowski, and it has a milder counterstaining effect when compared to Wright stain. So the Romanowski effect, if you see if at the core of the Romanowski stain, now the eosin it stains the acidophilic sites more with a pinkish or a slight pinkish hue, and mostly the cytoplasm is stained. Whereas the methylene blue has an affinity for the basic components, and the RNA and the nuclear aspects, the granules, are stained by the methylene blue. So this correct combination between these two plus of the azure dyes together will give you a contrasting beautiful image of your various granules and nucleus and cytoplasm in the cell. Now, Leishman stain, nowadays we get ready-made Leishman stains. There are some good companies making it, but you can also prepare it with Leishman powder, and this comes out beautifully if you dissolve it in acetone-free methyl alcohol and you allow the stain to ripen for a couple of days before using it, and this comes out really beautifully. Methylene blue stains the nucleus, eosin stains the hemoglobin, and acetone-free methyl alcohol, which is present in the Leishman stain, acts as a fixative. Now, why is it acetone-free? Because if it's not acetone-free, it will cause lysis of the RBCs. As the methyl alcohol fixes the peripheral smear to the glass slide, and it also preserves the morphology and chemical status of the cells. Now it is very important now before making the stain, you have a very well balanced rods to keep you may be staining 8 to 10 slides at one go. You have labeled them correctly, matching them with the tubes. And there are some labs which use barcoded labels, but in smaller laboratories where we don't have these facilities, make sure the names are written, the numbers and names are written in indelible ink, and then you place them on a staining rack. Very commonly, what I come across is this staining rack overuse loses the straightness of this staining rack becomes crooked, and then what happens is a few slides on one end of the staining rack stains well, and the other slide the stain drains off and the technician walks away without even observing it. So make sure the staining rack or the rod is straight and firm, and when you place the slides and pour the stain on it, the stain should stain the slides uniformly. So once you cover the blood smear with Leishman stain, count the number of drops, say 8 to 10 drops of Leishman stain to cover the peripheral smear. Then allow the stain to work for about 2-3 minutes. It should not be allowed to dry. Put enough quantity of stain. Then you put double quantity of the buffer solution. Buffer solution is usually of a Sorensen phosphate buffer. It should have a pH of 6.8. And once you put the buffer, you will find there is a metallic sheen that develops on top of the slide. Do not disturb this metallic sheen, because if you do, then it will settle onto the slide, causing mucks and particles of stain particles on the slide. It is best done with a plastic bottle with a long nozzle, and it should stain the slide from one corner. And also the buffer should be put slowly from the plastic dropper from one end, so that it is not disrupt it, so that it doesn't wash off the stain from the slide. Once the buffer is added, gently mix by blowing over the stain. Keep it for 8 to 10 minutes, and then the slide should be slowly tilted to uh, wash off the stain, or you could use a plastic bottle with distilled water with again a long nozzle, and this you can use to slowly wash off the slides. Make sure the metallic sheen or the stain deposit does not stick to the slide below. And once this is neatly washed off, allow the slide to drain. It is very important to maintain the pH of the buffer. It should be around 6.8. If it is increased, it's more alkaline, then the slide will look more pinkish. If it is acidic, the slide will look more darker, and you will not be able to see. Let us look at some examples. A well-stained peripheral smear, it should look pink or purple when you see it. And then the RBCs should stain orange or light pink. The nuclei is purple to blue. Cytoplasm is pink or gray, and the granules are lilac to violet. Eosinophils, of course, will have orangish granules, and basophils will have large dark blue granules. This is a picture of a pale staining slide where the buffer is probably too acidic, or you have not kept the stain on for the sufficient period of time. So this kind of a slide, check the buffer, the pH of the buffer, check whether you have adequately stained it. Otherwise, you will have to repeat it. If this kind of a slide is a very dark slide where you cannot make out the morphology of the nucleus, and especially in malignant cases, you will need to look at the morphology of the nucleus to say for sure uh, that it is leukemia, or even otherwise the neutrophils and the nuclear morphology is not seen if this stain is so dark. In this case, probably the smear was too thick, or the stain was kept for too long. The technician put the stain and forgot to put the buffer in time. Uh, it could also happen because of insufficient washing. So correction would be to check the buffer, prolong buffering time, or shorten the staining time. Despite taking all precautions, you may have some artifacts. These artifacts could be due to sample collection, or aging of the sample, or inadequately maintained staining solutions. Now, like I told you, pre-analytics is very important. A difficult venipuncture, when you're probing and fishing within the veins, causes platelet clumping, or there could be microclots resulting in decreased counts. Then shearing of RBCs may be seen, which mimics hemolysis. If it is a low sample volume, there could be a shrinkage of RBCs, due to which MCV will appear low and MCHC will increase. And the RBCs may also show crenation. If you don't mix the anticoagulant well with the sample, you could find platelet clumps, and the hematology analyzer may give false low platelet values. If the sample has been collected from an indwelling catheter, then it will be too diluted. These will also affect both your hematology values, and it will not correlate well. And rough handling of the tubes, like pushing the blood through the needles or shaking the tubes vigorously after drawing, will cause hemolysis and platelet clumping. Now, storage artifacts are something that we see very routinely if the smears are not made within the stipulated time. Once the samples are collected, it has to be stained within an hour of collection. The EDTA, I told you, is hyperosmolar, and it will change or alter the morphology of the WBCs, the RBCs, and the platelets. This can also happen when your logistic aid is carrying the samples in hot sun, and he's delaying it, bringing it to the lab. So all of these causes can give rise to sample related or storage artifacts. So you come across nuclear swelling, and then it undergoes breaking, and there are vacuoles within the cytoplasm. Platelets undergo clumping and degranulation. So to prevent all this, the smear has to be made within an hour of sample collection. Sometimes if you're in a hospital, you also have the added advantage that you can go take a finger prick peripheral smear. Finger prick peripheral smear gives you beautiful morphology of the WBCs, but it can give rise to some RBC clumping and platelet clumping as well. So there is a technique also to make finger prick peripheral smears. The third finger from the thumb is usually used because this is the least innervated and causes least pain. Once a lancet is uh, pricked into the pulp of the third finger, the first few drops are wiped away, and the next drop of blood is taken on a slide and smear made as was described earlier. Type of EDTA also matters. K2 EDTA is the preferred anticoagulant. Blood to anticoagulant ratio is important, and we should ensure that we're collecting the correct amount of blood in the EDTA vacutainers. Otherwise, we come across nuclear and cytoplasmic changes in the WBCs, altered platelet morphology, and also RBC show crenation. Several papers have been, it's a very hot favorite of postgraduate students as a thesis topic. They study EDTA-induced morphologic changes. This is one such paper. And in the first hour, there is no significant change in either the WBC, RBC, or platelet morphology. But as time goes, there are vacuoles which appear in the cytoplasm. Nucleus undergoes lobulations, and if they're very old, they may show blebs and rupture, almost making it impossible for you to identify the type of cell. You should never make an attempt to report on a poorly preserved sample or even a poorly made peripheral smear. We are always faced with time crunch. There is a lot of workload, and the technician also gives you a smear which is not stained properly. So in order to beat uh, the time and meet the requirements, you compromise, but you can miss out on a lot of important things. You can miss out malarial parasites. We have come across many times in a understained smear, a malarial parasite is missed and patient does not get the right treatment. So it is very important to patiently make the smear, allow the technician to stain it properly and go through it correctly. Now, once the stains are made and stored in bottles, if the caps are not covered properly, or if there is mixing of the stain with some water droplets in a humid weather, or it's kept next to a sink, and water droplets from the sink has fallen into the stain bottle, these can all give rise to water artifact. So we should take care to preserve our stain bottles and buffer bottles carefully. Buffer needs to be prepared on a daily basis, especially in humid weather. This can get altered. Stay precipitate can also be seen, what we call as mucks on the smear, which can interfere with our evaluation of the peripheral smear. It could be due to an old stain or because of inadequate rinsing. Like I told you, it is very important when you're washing the slide also, wash it from one corner with a bottle which has a long nozzle, which will slowly wash away the stain and the buffer from the slide. Drying artifact we come across when smears are not sufficiently air dried before staining. So the moisture in the slide can affect the morphology. Here, what you're seeing is RBCs with some refractile structures inside. So this is due to moisture droplets. And here in these RBCs, you're seeing some pinkish dots, which can be mistaken for malarial parasites. This is because of the moisture present in the near the RBCs, which have taken up the eosin stain from the Romanowski stain that you have used. Some of the causes of a poorly made blood smear include a very large drop of blood or a very small drop of blood. Slide is pushed in the spreader slide is pushed in a jerky manner, and you don't keep the contact of the spreader is not in complete contact with the slide, so the entire edge is not in contact, and then the angle is altered, or you have pushed it across the slide to go right up to the edge. So, and then there are holes in the films when there are slides which are not neat. So these are some of the causes of a poor blood smear, and these are some of the examples. Uh, this is because of a spreader that has a chipped or a roughed edge. Here, there is the technician is not confident of his movement or has made a jerky movement, and that is why you get this kind of smear. Here, it is pushed too quickly. Here, the drop of blood taken is very small. Here, the technician has not allowed the smear to spread along the spreader, and this is made on a dirty slide, uneven pressure on the slide, and here there is a time delay. Just give me a moment, please. So some biological causes of a poor blood smear include presence of cold agglutinin, where RBCs will clump together. RBCs are sensitized with IgM antibodies, and when, especially in cold weather, as soon as the blood is collected, the RBCs will start clumping. And when you have such a condition, you have to pre-warm the syringe and the needle before attempting to collect. And then you can keep the sample in a water bath for some time before feeding it into the analyzer. Lipemia, when the triglycerides are high, sometimes holes can appear in the smear. Nothing much you can do about this, but these are some of the biological causes. Rouleau formation can be seen in certain conditions where the myeloma and other conditions. Now, preparation of a thick smear. This is most commonly done for identifying malaria and microfilarial parasite. For this, you take 4 drops of blood in 4 corners. You make a large, thick smear out of this and allow the smear to dry thoroughly. This smear should not be very thick. You should be able to read a newspaper print through the glass if you keep it. If it is too thick, then once you try to stain the slide, it will get washed away. After making the smear, keep it in, wash it in, put it in distilled tap water, 5 to 10 dips in tap water for dehemoglobinization, where the hemoglobin from the RBCs will just elute out in a pink solution. Fix the smear in methanol and then stain with Giemsa. This also should be done within an hour of collection of the sample, and it helps in identifying malarial and microfilarial parasite in endemic areas. But to get a better morphology, a thin smear is always more useful. Like for every procedure that is done in the laboratory, quality control is very essential. As far as peripheral smear staining is concerned, you should keep records of the staining procedures, the pH of the buffer used, have a proper SOP. For making, there may be new technicians joining, they will not know how much time the stain has to be kept, how much time the buffer has to be kept. So proper SOP, they should all be trained, and documents of staining records as well as the buffer should be maintained. Proficiency testing is done for both the technicians as well as the persons reporting on the peripheral smear. The best way to do this is if you're enrolled with ECAS, the slide sent by the ECAS laboratory can be used to given to all the reporting pathologists, and then it can be matched with the ECAS report as a proficiency testing module. Now, once we have made the smear, there is a stepwise manner how you're going to approach it, how you're going to interpret it. First, most importantly, after the slide is thoroughly dry, you will put up a small drop of oil, spread the oil across the peripheral smear, and keep it under low power or scanner view. You're not going to see any morphology of RBCs or WBCs, but why is it important to see in a low power or scanner view? This is because you're going to pick up any clumps or fibrin clots in which is especially in a case of thrombocytopenia or a leukopenia case, you're going to ensure that there are no clots present in the smear, which has resulted in the low white cell count or the low platelet count. You should choose an area of the smear which is where the RBCs are just about to overlap or just overlapping. And that is the area of the smear you should use. The edge of the smear or the thick part of the smear is never used. The thick part of the smear, the WBCs look all clumped, and their morphology of the nucleus is not clear because this part takes a longer time to dry compared to this. Here, the nucleus is more open, and you will not be able to appreciate the morphology. The correct part of the slide where you're going to see is just behind the tail and where the RBCs are just touching or overlapping. It is a very common mistake many new pathologists make. They describe these as spherocytes, but these are flattened red cells and they are found in the tail end of the smear, and where all these WBCs are caught up, which is known as tailing. Tailing is nothing but the heavier cells, the WBCs, the monocytes, the neutrophils are all caught up in the edge of the smear, and in the analysis of rouleau formation is made if you are seeing this part of the smear. So it is very important to select the right area of the smear to understand the morphology of the various cells. These are some other things, what I told you, can be picked up when you're seeing under low power or scanner view. These are the clumps of platelets which you're seeing in the edge of the smear, and the rest of the smear will show very low platelet count because all the platelets are here at the edge. They have clumped here. Here they are all caught up in fibrin. Here some of the WBCs are also caught up in fibrin. So you have to rule out these things when you're seeing a peripheral smear, and if your analyzer has given you false low counts of platelets or WBCs, you can always say that the counts are not accurate and a fresh sample is requested for the same. Then you go on to high power view. High power view, you can make out the RBC morphology, and most of the times if they are normal, you can do the differential count also on high power view. WHO recommends that at least 200 cells have to be counted as part of the differential cell count. But I don't think in many laboratories we go beyond 100 cells. But if it is part of a bone marrow examination, 200 cell differential count is an absolute must. So, like we told, you choose an area of the smear where the RBCs are just overlapping and just beginning to overlap, not completely overlapping. Then you can also make, if the smear is made properly, you can also correlate with the WBC count received on the analyzer with the count on the smear. If you count about 10 fields and take the average number of WBCs per high power field, multiply by them by 2000, you get the approximate WBC count. That way you can verify whether your counter analyzer is also working fine if your smear is beautifully made. Then we go on to oil immersion to study the morphology of these cells more clearly. Especially so for malarial parasites, you can pick up malarial parasites. You can pick up now morphology of abnormal WBCs, especially the blasts, the ore rods, the nuclei, the nucleoli in them. All of it can be picked up only by oil immersion. Do not skip the oil immersion. Even if you're doing a differential count on high power, make sure you're putting the slide under oil immersion and scan at least 15 to 20 slides in a normal case, and of course more numbers if it's a abnormal slide, but make sure you observe every smear under oil immersion. Here you can also roughly estimate the platelet count by taking an average of at least 5 to 6 fields, and there are differential theories and 10 whether they should be multiplied by 10 or 15,000, but 15,000 is the more accepted figure. So these are the malarial parasites, this is a blast, and this is a giant platelet. Any idea what this is? Is this a malarial parasite? No, these are platelets sitting on RBCs, giving you an impression that this is a malarial parasite. So when you put it under oil immersion, you're able to get a better view of this, and you'll not miss the right diagnosis. You'll not make a wrong diagnosis by calling it a malarial parasite. So there are challenges in manual peripheral blood smear reviews, and this is because they are labor intensive and time consuming. You need to have a lot of patience when, especially in a center where there are high volume slides and there are a lot of abnormal slides, shortage of manpower. It is definitely labor intensive. You resort to counting just 50 cells or 25 cells, multiplying them by 4 and to arrive a differential count. And all reporting people may not be adequately trained as well. And what one sees as normal may be seen as abnormal by another person. There's a lot of lack of standardization. So these are some of the challenges in manual peripheral blood smear review. To overcome these, definitely more training sessions have to be conducted, and proficiency testing of all the reporting pathologists, reporting people have to be done regularly, and if required, additional training has to be given. But the technology has impacted this quite a bit. Now they are increasingly addressing the inefficiencies of manual peripheral blood smear analysis, digital imaging technologies, artificial intelligence, and deep learning has revolutionized the way a pathologist views the peripheral smear, and it has played a big role in diagnostic precision and also improving the lab workflows. So these are some slides Dr. Renu shared with me, what they are doing in SigTuple. These are some images from their AI 100. Thank you, Dr. Renu, for sharing me these cases. So with the advent of automation, the smears are scanned by analyzers, their digital technologies. We see these beautiful microcytic hypochromic cells predominantly, and sickle cell, the sickle cells also over here, and sickle cell was easily picked up. and HPLC was further suggested. They can also pick up platelet clumps, normoblasts. Normoblasts, many junior pathologists tend to miss these. They are counted as lymphocytes occasionally. So these advancements have picked them up beautifully. And this is another case, what Dr. Renu shared me was 61-year-old male patient presented with fever and hepatosplenomegaly. They picked up nearly 87.5% blasts, and they were confirmed after the slides were examined under the microscope as well. So these, I think Dr. Renu will give us a little more insight after my talk, how many fields they can actually scan and uh, put up in front of the pathologist, especially because when pathologists are not there in the lab and after their working hours, they can pick up these beautiful cases and alert the clinician for immediate treatment. So, some of the things to remember from this talk: peripheral blood film is invaluable in characterizing various disease. And despite advances in hematology automation and application of molecular techniques, peripheral blood film has become a very important diagnostic test to the hematologist. A good quality smear, thorough examination, and proper interpretation in line with the patient's clinical state should be ensured by the hematopathologist. Automation of peripheral blood film has emerged as a key area of research and development. Mind you, even for these, the smears have to be well made and they should be well stained. Of course, we have automated slide makers and slide stainers, but if they are being done manually, all the points that we discussed has to be kept in mind. And evaluation of a peripheral blood film is most essential in giving a complete bone marrow report. So with that, I come to the end of my talk, and I over to Dr. Renu for her insights, and then if we have some time for some questions.
Thank you so much, Dr. Priya. It was indeed a very eloquent and a very expressive way that you have delivered the practical insights of interpretation of peripheral blood smears. Knowing something theoretically is one aspect, but yes, applying that day to day, and when we get the challenges in day-to-day reporting, and that's where the expertise comes, right, with years of practice. And the pearls of wisdom that you have shared, I'm sure would benefit all our viewers here today. Thank you so much for that, and for also bringing out the automation and the digital aspect of it. Like Dr. Priya mentioned so beautifully, there is a big transition that is coming up in our practice today as pathologists, as we are seamlessly transiting, from a flow of manual microscopy to a more automated a way, or even a digital way in which we're trying to look at all these images today. The thought process is still the same. The way we're going to maneuver through these smears and bring about a diagnosis using our intelligence and our knowledge is not going to change. It's just that the way we're going to be viewing it and taking the aid partly from artificial intelligence and looking at it in a digital platform, and something that would bring about more amount of standardization, reproducibility, scalability, eliminating biasness, ambiguity of the human mind, and of course, which will also help you in research and education as we are looking today. So we intended to make this series a very, not just educative, but also casual, interactive, a sense of awareness, and also knowledge sharing. We would really be very happy to have questions coming up from the audience, some of the feedbacks, and also your experiences where we could really learn from each other. So with that, I would like to end what I'm saying today and would like to hear more from our viewers today, and to see what you could throw into further insights of what you've heard, or if you have some specific questions, I'm sure Dr. Priya would be very happy to take them too. If you have any questions, do raise your hands, or you could type it into your chat box, and we would be happy to address that as well. We will also be sharing the video with everybody who is registered with us today on your email. So even if, we have something here at the chat box. Let me just open that. Yes, Dr. Sangvi, please come on the video, sir, and please do tell us what you have to say.
Yeah, good evening, everybody. Just a short point I would like to add to what Doctor has been elaborately explained to us all this while. Moisture also plays a very important role in any kind of staining. So we always have to keep in mind the moisture conditions of a laboratory as well as ambient moisture conditions. Now, this is a time when there is a lot of humidity due to the monsoon. So we need to tweak our staining times according to the moisture conditions of any place. So that's something which I would like to add here. And this is probably going to benefit a lot of viewers and young doctors and technicians also who want to kind of standardize and master their staining techniques.
Absolutely, Mr. Sangvi. So it is important when you make any tweaks to your staining procedure, all the information passes on to the members of the team as well. And then again, when you change the staining techniques, it is important all of them come to know that yes, this change is made in the staining procedure. True. And it is important to
So
keep
yeah,
your staining bottles tightly covered when not in use.
yeah, precisely. Especially when you have the Leishman stain or the modified Leishman staining procedure, if your bottles are not tightly corked or tightly stoppered, the moisture will, in fact, it will wreak havoc in your entire stain. Your stain will not effectively stain the azure will not actually come up during this staining procedure. So that's what we have noted. We need to either change the staining bottle or throw away the entire stain preparation.
Yes.
So it's very important to keep a check on the moisture conditions of any staining place or the staining environment. What we usually do is we do the staining in a place where there is about a relative humidity of about 40% in the laboratory. For that, we always keep our air conditions on so that the humidity is controlled.
Thank you for sharing those deep insights. Dr. Sangvi owns a standalone lab here in Mumbai, and one of the pathologists who actually looks into the pre-analytical aspects of it, and that's exactly what you're highlighting. And we all understand how important pre-analytics is needed in lab practice today. It all starts from pre-analytics and then comes your analytical and then your post-analytical. So if you are very sound in your pre-analytics, it's a smooth workflow and your final impression will also not be hampered. But yes, the challenges are numerous, and that comes with learning when we actually start our practice in the lab. Thank you for sharing these
True,
important
true.
points with us today.
Thank you. Pleasure.
Do we have any other questions? Or some of your experiences, what you would probably face in your lab? We would be happy to hear that as well. I hope that today's session was educative and informative. A lovely pictures presented by Dr. Priya. Thank you, Dr. Priya, for taking that effort for showing us all those illustrations. Goes a very long way when we're actually trying to explain about these challenges and the kind of errors that actually come by, right? And that's some of these things we only learn when we are actually into practice, and manual microscopy teaches you that a lot. We would like to even hear from the audience at a later point of time. If you do have some queries or any kind of questions, be free to email those questions to us and we'll surely get back to you on that. We are going to be coming up with more informational and important topics, as Dr. Priya already gave you that outline at the very beginning of the presentation. So watch out for the next topic. It's going to be the morph codes of RBC morphology. I'm giving you a little bit of sneak peek into what the topic could be. We will definitely alert you on the timings and the date on when this topic is going to be presented this month. And so that you can come up with your questions beforehand itself and make this as interactive as possible. And that's something that we would even love to hear some of the experience that what you would have had in your laboratory practices as well. So we'll wait for another minute or so if anybody has any questions. anything at all, even if it is a question. That's the whole reason of keeping this format of education, where even if you feel the question is very basic, if you feel the question doesn't sound too good, please be, like very free to open up and have this discussion with us. We are here to guide you and here to help you out, and also to learn from you as well. So that's the whole intent. We will be sharing the video with all of you. So probably you could also pass it on to other trainees in the department, other students as well, if you have some connections, or junior pathologists who would love to hear topics on the ones like we have been discussing. We would encourage that as well, and also to have more of you in the next seminar as well. So if there are no more questions, I think for today we can end the talk. Thank you, Dr. Priya, again for taking your precious time out. And thank you for all of you for being here on a Saturday evening and taking your time out as well and making this a very good success. Thank you so much. And we look forward to seeing all of you again in our next session.
Thank you, Dr. Renu. Thank you, everyone.
Bye. Have a good evening.